Let us move on to neuromuscular junction disease, Myasthenia gravis. So we'll be having a debate in next half an hour on thymectomy in Myasthenia gravis, whether to go ahead with it or not. And the this debate will be moderated by Professor Vinay Goyal sir. Sir is currently Director of Neurology at Medanta, NCR, Gurgaon, and he has been former professor at Department of Neurology, AIIMS, New Delhi. Sir is currently president of Movement Disorder Society of India, and he's editor-in-chief for Indian Academy of Neurology. And we can go on and on about Sir's awards and memberships and honors. Sir has numerous publications and in international and national journals and book chapters. Sir's special interests are in movement disorders and myasthenia gravis, which takes us to the debate of the day, for which two brilliant senior residents from both the institutes will be joining us. Dr. Dhawal Narang, a sixth semester senior resident from Department of Neurology, PGI Chandigarh, who will be speaking in favor of thymectomy, and Dr. Ankit Goyal, fifth semester senior resident from Department of Neurology, AIIMS New Delhi, who will be speaking against thymectomy. So over to you, sir. Professor Vinay Goyal, sir.
Thank you, Priyanka, for the kind introduction, and thank you, Professor Padma and Dr. Vivek Lal, for inviting me to moderate this session. And I'm actually looking forward for this. This is a topic which is very close to my heart, and I'm sure the brilliant students are going to justify themselves. So both are correct, first of all. Nobody's wrong. So let's start.
Dr. Dhawal Narang, sir, you can start sharing your slides, sir.
Yes, 1 second. To start my debate on thymectomy in myasthenia gravis, to do or not. First of all, I would like to thank the distinguished faculty and all my dear friends for giving me the opportunity to speak at this wonderful forum. Now, without any further delay, I would like to start by saying that the word myasthenia gravis means a grave muscular weakness. Grave itself means severe, which means more than average. This is an appropriate term fitting the disease, as more than 20% of the patients of untreated myasthenia gravis progress to crisis within a year. Now, thymectomy is not a new concept in myasthenia gravis. Thymectomy is known since 1901, when Weigert first noted the association between thymus and myasthenia gravis. It was first described by Schumacher and Roth in 1913, when they demonstrated clinical improvement of a patient with myasthenia after removal of a non-neoplastic gland. It was further elaborated by Blalock et al. In 1939 and Keynes et al. In 1949, who have demonstrated the beneficial effect of thymectomy. First large retrospective case analysis of 1,355 patients was published by Perlow et al. In Green Journal of Neurology, which demonstrated a near very significant benefit of thymectomy with a relative remission rate of approximately 2.4 with thymectomy in myasthenia gravis. But it wasn't until the year 2000 when the first systematic review was performed by Gronseth and Baron on behalf of AAN, again published in Green Journal of Neurology, who have conducted an analysis of 28 controlled non-randomized studies comparing the outcome of patients with or without thymectomy, who demonstrated almost conclusively positive correlation between thymectomy and favorable outcomes. However, it is still a debate. Why Why can't we accept the results? Because there was no randomized trials. Now I would like to start by repeating the words of infamous Carl Sagan that the absence of evidence is not the evidence of absence. People will say, show me the evidence, show me the evidence, I need the evidence. So on this concept, first randomized trial of thymectomy in Myasthenia gravis was conducted and published in New England Journal of Medicine in year 2016, named as MGTX Trial. It was a multi-center randomized single-blinded controlled study which recruited 126 patients of age 18 to 65 years of age with disease duration of less than 5 years, MGFA class 2 to class 4 disease with anti-acetylcholine receptor positive antibodies, who compared an intervention arm of thymectomy with alternate day prednisone with a control arm of alternate day prednisone only. They demonstrated a very significant 2.85 point lower quantitative myasthenia gravis score and a reduced average prednisone dose, which by at least a third of prednisone dose with a p-value of less than 0.001, which were further substantiated by significant secondary outcomes, which included very high number of patients in minimal manifestation status at the end of 3 years, a significantly reduced need for hospitalization due to MG deterioration, lower average scores on MG-ADL scale, and a lower azathioprine usage. Also, I would like to mention here that the number of patients with treatment-associated complications unexpectedly did not differ between the thymectomy and the control group. This graph shows a significant lower number of patients without MMS in a thymectomy with prednisone group compared to prednisone alone. The benefits were sustained at the end of 36 months of observation. Also, the second graph on the right also demonstrates the increased proportion of patients with myasthenia gravis receiving azathioprine and IVIG in prednisone group. The benefit of thymectomy is not limited to the disease control alone. There is a significant survival benefit of thymectomy. More than 16% improvement in survival rates of thymectomized patients were conclusively demonstrated by Christensen et al., which were sustained not only just after thymectomy, but at the end of 3 years, 5 years, 10 years, and 20 years survival rates. Based on these above evidence, the AAN in 2020 issued a practice advisory for thymectomy in myasthenia gravis, which stated that all patients, clinicians should discuss thymectomy with all patients with acetylcholine receptor antibody positive generalized myasthenia gravis, the basis of class 1 level B evidence, and no patient should be denied thymectomy directly because of their disease status. On the basis of all this evidence and this recommendation, if you ask me, if I ever get myasthenia gravis, if I develop drooping of eyelids and muscle weakness with acetylcholine receptor antibody positive, I will choose thymectomy. I am willing to accept recovery from a sternotomy with a mortality of less than 1% in multiple studies and an average hospital stay of only 4.6 days, because it means a probable reduction to a third less prednisone, milder symptoms. I will have fewer hospitalizations for admissions, and I will have 2/3 less chance of having minimal symptoms within next 1 year, and that will be sustained over at least next 30 years. And also it is likely to improve both quality and quantity of my life. Thank you.
Sir, you have to stop sharing your slides.
Okay.
Are my slides visible? And am I audible?
Yes, Ankit, your audible slides are visible.
Okay. So as Dr. Dhawal has started the debate, the topic is thymectomy in myasthenia gravis, and I am I've been asked to speak against the motion. So I'll dive straight into it. The only thing I agree with Dr. Dhawal is that we need the evidence. That is right. So we know that if there is unambiguous evidence that if there is a thymoma or a thymomatous MG, if there is a tumor, it is better to remove from the body. So that is not being contested. But for non-thymomatous MG, we need to ask ourselves as evidence-based practitioners, what is the evidence? So Dr. Dhawal mentioned Gronseth Quality Standard Subcommittee report of AAN 2000, which showed that there was some association between thymectomy and improvement of myasthenia gravis, but which he carefully didn't, what he carefully chose not to mention was that they also said that the observed benefits could be merely a result of the multiple differences in the baseline characteristics between the surgical and the non-surgical group. Cochrane Neuromuscular Group in 2013 decided to do an extensive review, and after that review they found that not only there was no RCT being done for thymectomy in non-thymomatous MG till now, but the evidence which was there till now was only anecdotal, and it had a few observational studies and it was classified as class 3 evidence. So this was a line from the Cochrane review. So as Dr. Dhawal rightly said, MGTX trial was widely awaited, and let's go deep into it. Before I burst the myth of MGTX trial, to all the viewers and the residents who are listening, it is important to ask one question before you recommend thymectomy for a patient in the OPD. So is one randomized trial enough to subject a highly selective set of myasthenia gravis patients to an old surgical procedure when they could be in complete stable remission or achieve minimum manifestation status with evidence-based immunosuppression or even spontaneously with time? So with this question in mind, I'll go into the MGTX trial. So the MGTX trial study group excluded all patients who were anticholinergic receptor antibody negative, less than 18 or greater than 60 years of age, MGFA1 or 5. For practical purposes, they also excluded MGFA4 because only 3 patients were in MGFA4 out of the 117 patients or 120 patients which they looked at. The recruitment was questionable. 36 centers could only recruit patients out of the participating 67, which could tell us that there was maybe some resistance on the levels of physicians or resistance on the level of patients to undergo such a procedure. Only a meager 1.81% patients were randomized. So this is the baseline characteristics table. We have a quick look at it because we have very less time. So we can see that there are only 3 patients who fall into MGFA4 class, and the median duration of the disease is close to 1 year. We can see that 22% and 26% patients, that is a quarter of patients in each arm, were steroid naive. That means they had not received steroids earlier, but they were just for the sake of matching both the arms, they were thrown and they were pumped with high dose steroids, 100 milligram, almost 100 milligram steroids, which is too far away from routine clinical practice. Imagine having an MGFA2A patient and pumping her with 100 mg steroids, despite knowing the fact that there can be an initial worsening with steroids, especially in the bulbar symptoms. Also, they looked at the outcomes. They checked the QMG scores, which is a 39-point score like I've shown in the table. It has equal points for ptosis as well as for swallowing or speech difficulty. So a 2-point reduction in ptosis would not be that clinically meaningful or beneficial to a patient who has a swallowing or speaking difficulty. So diving into the results, the primary outcomes. So they took absolute QMG scores instead of delta QMG scores. I'll show you in the remaining slides what it means. And also all the major trials which have occurred till now in myasthenia gravis, whether it's the cyclosporin trial, whether it is IVIG trial, they have taken a cutoff of 3, greater than 3 or greater than 3.5. All this controversy could have been solved had they done a simple ANOVA or regression analysis for equating the baseline QMG scores. So this is the slide which shows that at the baseline, the QMG scores were 12.35 and 11.4. In their results, they had 8.99 and 6.15. So what they did was subtracted 6.15 from 8.99, put up a score of 2.85 on the basis of a 2006-year-old reliability trial showing good results with a greater than 2.3 cutoff. They showed that the result was significant. What they should have done was subtracted 8.99 from 12.35, the delta QMG score in the prednisone arm, the delta QMG score in the thymectomy plus prednisone arm, and that difference comes out to be 1.8. So which is less than their cutoff of 2.3. So these slides are just to show that the cyclosporin trial also used the change in QMG score. The IVIG and Plex trial also used the true difference in QMG scores, and the cutoff was kept as 3.5. This is the latest trial of eculizumab in myasthenia gravis, and J. Baron is one of the authors of this trial, who was also one of the authors of MGTX trial. So he also postulated that overall change in mean QMG score was better, and ultimately even that greater than 3 score was also not sufficient. It should be at least a score of greater than 4 cutoff. Coming on to the secondary outcomes, you mentioned that myasthenia gravis activities of daily living score was significant. However, the authors keep on rambling that the more time you spend, go away from thymectomy, in 2 years or 3 years, the difference would be more. But there was no significant difference in Myasthenia gravis activities of daily living score at 3 years. And that is the only score which takes patients' complaints into account. We also look at the subgroup analysis. There was no significant difference between prednisone naive patients. There was no significant difference in male population. And in a post-hoc analysis, there was both primary outcomes were failed in the post-hoc analysis for age greater than 50 years. So these are the just slides to show the results. MG-ADL, subgroup analysis of prednisone naive patients, male patients, absolutely no significant difference. And same for a post-hoc analysis of age greater than 50 patients. So let us come out of the MGTX trial for a minute. Apart from the MGTX trial, we know Zhou and colleagues had demonstrated that about 45.3% of the patients harbor a pre-existing anxiety, and that can only be worsened by an operative procedure, and the post-op myasthenia crisis can be precipitated in about 12.5% patients. That can not only cause increased intubation, difficulty in weaning, prolonged ICU stay. Coming on to the surgical techniques, there is a wide debate as to which surgical technique is better. Now, the authors used extended transsternal thymectomy, which has shown to have more morbidity and mortality, even in some articles up to 6.4%. Schrager and colleagues argued with the authors after the publishing of the trial that they had mentioned that the transcervical techniques were, despite being available, were not used, which have a far lesser morbidity, and it is almost an outpatient procedure. And we are not even currently discussing the less minimally invasive techniques such as VATS and robotic surgeries, which have shown to provide similar, if not better benefits and less side effects. So unless and until there is a direct comparison between the techniques of thymectomy, this will always remain a controversy. Coming on to another, Hughes demonstrated that in a long-term follow-up of the natural course of Myasthenia gravis, spontaneous clinical remission was almost seen in 20% of the patients, especially after they passed a timeline of 5 to 7 years. Also, in the MGTX trial, we can see in the prednisolone only group, the remission rates increased spontaneously from 37 to 47% at 3 years, which maybe can be interpreted as that the disease was itself after 3 to 5 years itself goes into some form of remission. This was also seen in the ambidextrous study, which was done by Dr. Vinay and his colleagues in AIIMS for azathioprine, that the duration of myasthenia gravis at 10 years was an independent and statistically significant predictor of remission. The relationship of thymectomy with time has always been conflicting. In the first study, we can see that in a retrospective study of 78 patients, the probability of remission increased as a function of time. That is, as we go on for 5 years or more, the remission will keep on increasing. But a conflicting report came from Roth and his colleagues, who followed myasthenia gravis patients for 13 years. That is the longest follow-up currently till date. So they found out that there was worsening and more deterioration of myasthenia gravis in 35% of the patients compared to improvement in 22% patients with time. So this is a controversy in itself. There are conflicting reports. Coming down to immunosuppression, a randomized the 1998 J-Palace trial of comparing azathioprine plus prednisolone with prednisolone demonstrated the benefit of azathioprine. But we have data from our own center to back it up. Again, like I mentioned, in an ambidextrous study of 117 patients by Dr. Vinay and colleagues in AIIMS, we found out that there were 33.3% achieved remission, out of which almost 31 patients achieved complete stable remission. That is, they were off pharmacological treatment and without any complaints or weakness. And azathioprine side effects were not seen in most of the patients. Only in 81% of the patients, 81% of the patients were absolutely side effect free. And you also pointed in your last slide that even in the MGTX trial, the treatment complications were the same. So it is not like that immunosuppression or azathioprine that has worse side effects than thymectomy. Again, reiterating the fact that in this study, we also found out that only the duration of the disease, more than 10 years, was independently and significantly associated with remission. So keeping all these points in mind, I would implore the residents or the people sitting in the OPD, before you refer a patient or counsel a patient for thymectomy, apart from the guidelines, you should also keep such evidence in your mind. The rest will be done in rebuttal. Thank you.
Over to you, sir. Professor Vinay Goyal, sir. we can start with the rebuttal by Dr. Dhawal Narang.
Dr. Narang, any comments you want to make on Dr. Ankit's presentation?
Sir, should I start my rebuttal?
Yeah, please.
Are my slides visible?
Oh, you have a slide for this? Oh, good. Okay.
Thank you, sir. Sir, first of all, like we were discussing about the safety of thymectomy and the long-term immunosuppression. Sir, I would like to mention that as I first noted that there was no significant difference in treatment-related complications initially. But sir, now I am going to talk about the treatment-related complications as observed during the follow-up period, which were not conveniently talked about by my friend Dr. Goyal. I would like to mention that almost all kinds of adverse events that are recorded here, including severe events, life-threatening events, disability-producing events, events producing medical or surgical intervention, even deaths and hospitalizations were noted significantly more in the group receiving prednisone alone compared to the group receiving thymectomy with prednisolone. Even sir, there was no death related to thymectomy or thymectomy related complications which were noted during the follow-up period. Now, also, I would like to mention that whatever side effects we talk about in thymectomy, so they will be during the initial hospitalization only. But now, in the group that receive long-term immunosuppressive therapy for myasthenia, we have to talk about the long-term side effects of immunosuppression medications as well. Over the follow-up period, which has ranged for as long as about 40 years in various studies, including many Kaplan-Meier survival curves, that almost all patients report having some side effects. The most significant study of till date has been published by Baki et al. In 2016 in BMC Neurology, which have reported the significant side effects of infections, weight gain, and diarrhea in almost 2/3 of the patients. And about 32 patients in the reported series, with total series of approximately 2,000 patients, have had reported serious side effects in the medical intervention only, and no such side effects in thymectomy. Thymectomy has been demonstrated to be a safe and effective procedure in many studies, starting from the year 1999, which in a Japanese study, they reported only a single death in a study of 94 patients. A subsequent study was conducted by a National Surgical Quality Improvement Program reassessment from 2005 to 2012, which demonstrated that there was no mortality in all the myasthenia gravis patients who have received thymectomy. Now, what about the cost? We have not talked about the cost of long-term immunosuppressive treatment. Thymectomy is a single-time procedure. Like a single-time thymectomy, even in a reasonably expensive center, like we are only using in government center, there is hardly any cost of thymectomy. But average cost of a single thymectomy would cost about 45,000 rupees, and including all the hospital expenses also, it would not cost more than about 2 lakhs. A study of such expenses was conducted by Sonkar et al. 2016 from PGI Lucknow, and they have noted that with marked reductions in the rate of myasthenic crisis and a reduced need for further hospitalization, the cost of patients receiving thymectomy easily outweighs the cost of long-term immunosuppression. Now, what about the other groups? Like my friend talked about the thymectomy in other groups, I would again like to quote that famous statement that the absence of evidence is not the evidence of absence. We don't have the evidence, we don't know whether thymectomy is effective or not because there are very less patients. Like thymectomy in MuSK-positive myasthenia gravis, it is a relatively rarer subtypes of myasthenia gravis, so we have not been able to do any controlled studies. But the few available studies which we have available suggest limited improvement in clinical outcomes or reliance in immunosuppression after thymectomy in MuSK-positive myasthenia gravis, especially the newer studies which have been conducted by Guptal JT et al. And Pasnoor M et al. Have noted reasonable clinical improvement in myasthenia gravis post-intervention status PIS score in up to 40 to 50% of patients after thymectomy. However, I would agree that evidence here is not sufficient and more studies are needed to confirm efficacy. Now, what about thymectomy in seronegative myasthenia gravis? Seronegative myasthenia gravis also show comparable response rates after thymectomy as their acetylcholine receptor seropositive counterparts, which were noted by Guillermo et al. In 2004 and further published in Journal of Neurology in 2016. In thymectomy in juvenile myasthenia gravis, again, we have multiple studies which quote that in children with generalized acetylcholine receptor myasthenia gravis, thymectomy is associated with significant clinical benefit. However, because of a variety of reasons, it is still not recommended as a class 1 evidence because of lack of randomized controlled trial. One of the largest systemic review performed till now by Medicity et al. Published in 2016 conducted a review from 144 articles published between year 2000 and year 2016, and they demonstrated that among 488 patients who undergone thymectomy, post-operative of myasthenia gravis status reported in almost 3/4 of the patients with a 29% rate of complete remission. Now, I would like to ask the audience, suppose if there is a chance that a young boy which you are seeing has at least 1/3 rate of complete remission, he will be free of immunosuppression for whole of his life. Would we not offer thymectomy? I would offer thymectomy. Whether they choose it or not is entirely their wish. Also, another group which was talked about, which was deficient in MGTX trial, was thymectomy in elderly patients. I agree there was not many trials previously, and the elderly patient subgroup in MGTX trial did not demonstrate any benefit. But subsequent studies, especially that conducted by Otsuka et al., who evaluated the role of thymectomy in myasthenia gravis in elderly patients as old as more than 65 years of age, have demonstrated significant benefit and concluded that thymectomy is an option in elderly patients, provided that the surgery is performed within 1 year of the onset of symptoms. But again, more studies are needed to confirm the benefit. Thank you for listening.
Ankit, you want to say something now?
Yes, sir. I'll start.
Reverse rebuttal? Oh, you also have slides. Usually rebuttal is a more of a verbal debate on the comments.
Yeah.
Okay. Fine. Oh, so you're all well prepared. Good. Carry on.
Yeah, so there are a couple of things which I think before I go into the rebuttal of the points which have been made by Dr. Dhawal, I think it is important to know what kind of patients you will see in the OPD, and at that moment what you decide. So let us take examples from our daily routine OPD settings. So this is a 30 years old lady diagnosed with myasthenia gravis 3 years back, presents to you with severe oropharyngeal and respiratory muscle weakness. So after stabilization, would you recommend this patient for thymectomy? Now, if we look at our evidence, the MGTX trial, we see that this patient falls into MGFA4 class. So the patient falls under MGFA4 class, but the MGTX trial had only 3 patients of MGFA4. So are these results generalizable in this population? So let us take another example. A 35-year-old gentleman diagnosed with generalized myasthenia gravis 2 years back, he presents to you with moderate limb weakness. He was previously tapered off steroids and was currently only taking pyridostigmine. Would you recommend this patient for thymectomy? Again, if you look at the subgroup analysis of the trial, the current evidence which is there is no benefit for the main gender. So how can we generalize the results to a male population? Let us take another example. A 52 years old lady, she was diagnosed with myasthenia gravis 2 years back, presents to you with just mild limb weakness, fluctuating mild difficulty in chewing food. She is currently taking only pyridostigmine SOS. Would you recommend this patient for thymectomy? Clearly not. As per the own guidelines, as per current November 3rd guidelines, citing the fact that the post hoc analysis in the MGTX trial showed no benefit for patients above 50 years of age, this patient is not a candidate for thymectomy. Let us take some other examples. Patients who are steroid naive, patients who have not taken steroids in their life, should we just pump steroids into them and then send them for thymectomy without even trying any immunosuppression? Let us talk about anticholinergic receptor antibody negative patients. There is no class 2, even class 2 or class 1 evidence for anticholinergic receptor antibody patients. Coming to the anti-MuSK population, Dr. Dhawal did show quite a large 110 patient study from DB Sanders, the Duke group. This was the group Guptill and the Donald B. Sanders Duke group, myasthenia group, who showed that in MuSK antibody myasthenia patients, they looked at about 110 patients. The fact to note is that only 40 of their patients underwent thymectomy, and this is the author's own admission. They say that the post-intervention status was comparable to that of patients who were not thymectomized. All thymectomized patients had also received immunosuppression therapy, making it impossible to confirm whether it was the effect of immunosuppression or it was the effect of thymectomy. So that is what I wanted to present, that it is a highly selective population which is left, which is eligible for thymectomy. What is that highly selective population? 18 to 15 years of age female who is steroid responsive or dependent, who is MGFA 2 to 3 class, and the duration of a disease is less than 3 years. This is the core eligibility of the MGTX trial, the evidence which we have till now. Let us take this example. A 25 years old lady who is acetylcholinergic receptor antibody positive. She's diagnosed with myasthenia at 14 months back. She's been tapered off her low dose steroids and currently having only mild limb weakness. That is, she's MGFA 2A. She has no history of bulbar weakness, no history of moderate to severe limb weakness. There is no episode of crisis. She comes to you in OPD. She's just been tapered off her steroids. So would you start steroids in this patient for her to achieve minimum manifestation status for at least 1 year, about 100 mg steroids? Would you recommend her for thymectomy without even having tried immunosuppression in a mild case? So this is what the debate is all about. So let us again concentrate on what some deficiencies were there which would hamper our clinical practice. So in the trial, there was a very slow recruitment. So it was definitely, if we remember, if we see the supplementary appendix of the article, they have said that they had taken a vote before the MGTX trial of 120 physicians, whether they think that the thymectomy would be beneficial or whether they think they would be uncertain. Almost 50 out of those 120 clinicians believed that they were uncertain or they were sure that the thymectomy would not work. So there is already a resistance on the basis of a practicing clinician whether to send the patient for a thymectomy. If you don't have conviction yourself, there is no way that you can convince a patient of myasthenia to undergo thymectomy. Second is maybe the patients also 120 patients refused to undergo thymectomy. Again, the methodology of the trial, wouldn't a direct comparison with azathioprine have been more prudent? This would have ended the debate right there and then. They could have taken azathioprine in one arm and thymectomy in another, and they could have easily compared the effects of both. Also, is giving high dose steroids, like I've completely again and again rambled on, to patients for 5 years in line with the clinical practice. Again, they took a QMG model which doesn't give equal distribution to ptosis or to swallowing difficulty or bulbar symptoms. By the author's own admission, a rash modeled MG Composite Tool would have been better. The MG Composite Tool gives 9 points for ventilator dependence and gives only 3 points rightly for ptosis. So it is not uniform distribution of all the points, and that can lead to a differential QMG score. Again, I have already enumerated the fallacies of delta QMG scores. I'll not repeat it. Again, the subgroup analysis and the post-hoc analysis. Apart from the MGTX trial, let us take this controversial relationship of thymectomy with time. So there is evidence that after thymectomy, as the years go on, maybe after 5 years or more, the remission rates increase. But there is also evidence that there are more relapses, more deteriorations, the more you follow up a patient of thymectomy. So good luck discussing this with the patient. So what would you tell a patient? Imagine a 23-year-old female sitting in front of you. You'll say that I want to recommend you for a surgical procedure. I'm not sure whether the effect will be there in 3 years or not. And there is also a possibility that after 5 years, you might have relapses again. Also, we've previously seen that the surgery exacerbates anxiety and it can lead to more myasthenia crisis. And the debate of invasive and minimally invasive surgical techniques, efficacy and complications, till there is a comparative trial of them, we can't be sure of that. Now, Dr. Dhawal mentioned cost. I knew he would do that. So he also mentioned a great article from SGPGI, which looked at the direct and indirect cost of myasthenia gravis. So if we look at, he said that on an average, a thymectomy patient would spend about 45,000. So it is written that almost 45,000 to 2 lakhs would be spent by myasthenia gravis patient on thymectomy. I say that it is 45,000 or 2 lakhs too much. So the indirect cost reduces with complete stable remission. The indirect cost is the loss of functional days which the patient has in severe myasthenia gravis. Even with thymectomy, it would reduce, but on immunosuppression, the indirect cost, the direct cost of admissions, of myasthenia crisis, of intubations, of increased hospital stays, that will far more than easily compensate for the rate of the immunosuppression drugs. Coming on to again to immunosuppression also, there have been excellent results with azathioprine which we have seen. There are also newer and upcoming drugs like complement inhibitors, eculizumab, which has already been proven by the FDA. There has been rosanolixizumab, which the trial is going on again with the same people who've done the MGTX trial. So FcRn inhibitors are also there in the pipeline, efgartigimod. So they are saying that even for refractory myasthenia gravis, even after immunosuppression has failed, there might not be need for subjecting the patient to thymectomy. It could easily be solved with eculizumab, like we do here off-label with rituximab, the data for which is again coming. So what I want to say in conclusion is that as clinicians, as the doctors who are prescribing thymectomy, we need to be convinced ourselves. We need to have that conviction that yes, there is sufficient class 1 evidence which is available so that this patient falls into the category where I would recommend thymectomy and she would benefit from that. So read the available evidence thoroughly, discuss with your patient, make an individualized case-to-case decision. Thymectomy may be considered in acetylcholine receptor antibody positive generalized myasthenia patients who fail to respond to an adequate trial of immunotherapy or have intolerable side effects from the same. So on this note, I would end, but I would also ask the residents if they've already not read it, Dr. Vinay sir's viewpoint in Annals of Indian Academy of Neurology, which was published last year. It is almost about the debate which we are having. Thank you.
Thank you, Ankit and Dr. Narang, for a wonderful debate, and I'm so happy to hear it. And I must thank again Dr. Padma and Dr. Vivek Lal for involving me in this, because after some time I've been hearing this debate. If there is a choice, I would like to have a vote from the audience, because or the people who are present here, that how many will vote. We should have done this advance before you have presented. How many want to do thymectomy or not? But I have few points which I'm sure we have mentioned in our article also. If you look at this, they screened 6,500 patients of myasthenia gravis and included only 1.8% of the total patients. So you are going to do a procedure on a patient where there is a highly selective group of patients. So they excluded negative patient, they excluded MuSK patient. I'm sure they excluded thymoma from the study, which is quite well. There are 2 points which are absolutely unacceptable to me. One, they did open thoracotomy. I think in Institute we did open thoracotomy almost 15-20 years ago. So it's something like, sounds like an obsolete procedure we are trying to do. So if you ask me to do a procedure which we never used in last 20 years, and now I say there is an evidence, so I would not accept it easily. Second, the worst part was, which rightly both parties have also emphasized, use of prednisone. I was never convinced why they had, they try to equalize the group of patients and push prednisone. I think in real-time clinical practice, we never do that, never ever do that. So you are trying to believe a trial in which the real-time patients are not involved. It's an artificial group of patients who are pushed into the prednisolone up to 1.5 milligram per kg. But I wonder where we ever give that amount of this. Third major thing is, like I'm a fan of azathioprine, especially in Parkinson, this myasthenia gravis. So if any of my patient who is not doing well will be ultimately on azathioprine, and quite a high dose of azathioprine. So this is another group of patients where they have not used disease-modified drug from the beginning or when they are not doing well. So they are I would say they were, for the sake of trial, they have been kept out of the drugs which are beneficial to the myasthenia gravis. So that will be another of my reservation. If you look at the 5-year follow-up trial, only 45% of the patients are being followed now. So there is a 55% loss. So you are trying to tell me a data from 5-year follow-up that 55% of patients, we don't know what happened to them. So my teacher, Professor Prasad, I remember always when I quote anything like this, that you have to always do a best scenario and worst scenario. So keep them at the worst scenario. If you keep 55% of the patients in the worst scenario, I don't want to calculate what will be the result of this study. And regarding juvenile, I think I never advise doing thymectomy below 18 years of age, because keeping in mind that thymus has its role in immunogenesis. So those students, I must say, you can read an article in NEJM which was published. The title is Thymus, and it was published in 99 or 98. I think it was 99 which was published. And please read that article on thymus. regarding elderly, we all know the thymectomy is not beneficial immediately, or the idea is to give a long-term immunostability. So after 60 years is my cutoff personally. I can't justify this, why I'm keeping 60 as a cutoff. But I don't advise them thymectomy for the simple reason you are trying to do a major surgical procedure. And these are the patients who are likely to have a worsening. And I would always like to, if somebody comes to me at 6 years of age, from day one, I would like to give disease modifying drug rather than only giving pyridostigmine or small dose of steroid, because I know these are the patients who are really vulnerable, and I don't want them to have any worsening over the period of time. And that's my basic strategy, to give them disease modifying drug. So rightly they've excluded elderly from this, which is a very good point. I would and now we do most of my patients who undergo video assisted thoracotomy. And I'm sure all of my residents are exposed to this. The patient who undergo VETs can walk actually home on next day morning or third day morning, because it's such a simple procedure. There are only 3 4 nicks, and you have got 4 stitches around the body, and that is as simple as this procedure. Other point was they were giving steroid for 5 years. I wonder why they were giving steroid for 5 years. The patients are doing fine. I must express this. We also wrote in our paper on azathioprine. I think this point is covered there. Uh, like I'm also a student of Dr. Bihari, so this will remind me of Professor Bihari. When I became young faculty, I used to see her large number of patients were on steroid. And like all of us have an aversion to steroid, and that's the time we started using a lot of azathioprine. So ultimately, if you ask me, none of my patients should be on steroid at any point of time. Over the period of time, 3 months to 1 year period of time, I would definitely try to take off the steroid and put them on azathioprine. I may be absolutely biased about azathioprine because of my extensive use and confidence, and I think it's one of the very safe. And there is a wonderful paper about some neoplasm in azathioprine. You can read that paper. It mentions some of the malignancies which can be precipitated by or maybe associated with azathioprine. But maybe I'm lucky that enough in last 20 years, I don't remember often any of my patient coming back to me that I have developed this particular malignancy. The commonest thing which I have noticed, which is dreadful or I'm always scared, is tuberculosis. There's quite some of my patients who develop tuberculosis, which is, I don't think this is a benign disease, and I'm always scared of tuberculosis because the patient of myasthenia gravis is developing tuberculosis, and they develop sometimes pleural effusion or frank pulmonary tuberculosis. I don't remember any of my patient developing tuberculosis meningitis because he was on immunosuppression in myasthenia gravis. I often, maybe there are cases there, but I often don't remember this. So my confidence in the azathioprine is a quite lot. I must have used azathioprine, and I use azathioprine quite a high dose. Also, the learning point here is I get a lot of patients of myasthenia gravis who are not controlled, and they are on azathioprine. So the magic, what I want to do is increase the dose of azathioprine. My target dose for azathioprine in myasthenia gravis is 3 milligram per kg body weight, and not 2 milligram per kg body weight. And I must mention that quite some of the patients who are not controlled with 2 milligram, then when I make it 2.5 milligram or 3 milligram, and they get controlled. So over the period of time, I've learned that I want to increase the dose of azathioprine, but provided you are monitoring their LFT hemogram. I would never see a patient in follow-up who has not done LFT hemogram, because that's my basic point to see, and I would advise him to come day next month.
are only brave participants. So for our participants, we have a prize in the form of a book, Fundamentals of Evidence-Based Medicine, written by none other than Professor Kameshwar Prasad sir